finish it today or not, I don't think so.
Possible.
We can have another way. You can ask and I can answer you. Isn't it better?
Yes. Can you explain the reflex?
The reflex?
Yeah.
Which reflex?
All of them.
So it's a lecture.
Yes, that's how.
Okay, I'll start and I will finish at 4:10.
Okay.
No problem. Can you extend the time?
It's not
to 6?
He doesn't have time.
I have time. I can stay here till 5.
Okay, that's it. Okay, not bad.
Yeah, but you are ready to come at 4:10.
Yeah, that's
Right? I think I'm not worried about that. Okay. So spinal cord is involved in different type of movements. So, 4 type of movements. Reflexive movements.
Stimulation.
So, it's an automatic type of movement in response to sensory stimulation. So we need sensory stimulation, but there should be a receptor here and a type of stimulation. So reflexes can be somatic or autonomic, right? So they can involve somatic part of the body like muscles, skeletal muscles, or autonomic reflex. One example for autonomic reflex, do you have any idea about that?
Withdrawal reflex from pain.
Jaw reflex?
Withdrawal.
Withdrawal reflex from pain?
Yes.
So it's a somatic reflex. Because it involves skeletal muscles.
Stretch reflex.
Okay. Breathing, for example.
Breathing, do we have any reflex in breathing?
No.
If someone, for example, is was suffocated, they take a deep breath. Unconsciously.
Maybe, so this is maybe one autonomic reflex. But the best one, a better one.
Eyelid movement.
Eyelid movement. So why not pupil reflex?
It's
So
from
you shed light onto the eyes, the pupil.
But it requires an external stimulus, right?
Yeah, external stimulation is a light.
This one is
So, baroreceptor reflex, you know it. There are a lot of gastrointestinal reflexes, right? So, autonomic and somatic. The second type of movement is rhythmic movement, like walking. So it's only repetition of one type of movement, okay? Repetition of this or this. We only repeat it. So it's rhythmic or scratching. Okay? So, here we don't need a receptor or a stimulation. Everything can start from the brain. The brain can give the command, and then movement starts and it goes on. Right?
You talked about the cerebellum and rhythmic movement.
Cerebellum?
Yeah.
Cerebellum, I told you before, cerebellum cannot send direct information or direct command to muscle or automotor movement. It can only affect other motor systems. So, from cerebellum we don't have rhythmic movement. Okay, it can help other centers. Only this. The third type of movement is postural, which is related to the position of the whole body. Standing position, sitting, lying, flexed position, right? So everything. So, third type. Fourth type is purposeful movements or voluntary movement. You can decide about the movement, especially by your hand, and you can do that, right? So, spinal cord is necessary for all of them. Without the spinal cord, you cannot do purposeful movements. Because the command starts from the brain, but it comes to the spinal cord. From the spinal cord, you have spinal nerves innervate muscles. So in order to contract the muscles, you need the spinal cord. Postural movement starts from the brainstem, but it's performed by a spinal nerve, so you need the spinal cord. But for rhythmic movements and reflex movements, spinal cord alone can control the movement. It doesn't need higher center. right? So it can start reflex movements by its own, right? On its own. So these are different type of movements. To do these movements, the spinal cord have 3 different type of structures or organization. First one is segmental organization, which means you can consider the spinal cord as 31 segments overlaid. So the spinal cord is like a column of segments, pile of segments. Right? Each segment does some sensory and motor functions. And these sensory and motor functions is similar for all of these segments. But only the region of the body which is affected by that segment is different. Right? So segmental level organization. So reflexes are performed or controlled by this type of organization. The second type is propriospinal, which means there are some neurons in the spinal cord that send their axons vertically upward or downward, so they provide connection between different segments. Propriospinal. The third type is descending motor pathway, which starts from higher centers, like from brainstem or from the cortex. But they send a fiber through the spinal cord down to the alpha motor neurons, right? So, 3 types of sectors. Let's 3 types of structures. Let's see the segmental one here. So in the segmental organization, we have ventral horn, dorsal horn, intermediate zone. Dorsal horn is sensory, you know that, right? In the intermediate zone, we have interneurons, and ventral horn is motor. So in the ventral horn, we have 2 types of motor neurons. The larger one is called alpha motor neuron. The smaller one is called gamma motor neuron. You know the fibers. A alpha fiber is myelinated and is very thick, right? But gamma motor neurons are smaller. They use A gamma fibers. Both of them are myelinated, but this one is thick, this one is thin, right? This one is faster, this one is slower. So both of them are present here in the anterior horn. So interneurons here make connection between the sensory part and motor part of the spine. So there is an arrangement for alpha motor neurons in the ventral horn. So let's consider that and imagine that this one is a cervical segment. So you know that arms are innervated by cervical segments, right? So in the cervical segment, in the ventral horn, we have some alpha motor neurons that go to the muscles that actually move the distal part of the arm. So they move fingers. They are located most laterally. But in the most medial part, we have alpha motor neurons that innervate axial musculature. Muscles of the neck, muscles around the spine, muscles of the trunk, right? So axial musculature. In between, we have alpha motor neurons that innervate proximal part of the arm. So alpha motor neurons located most laterally innervate distal part. Alpha motor neurons located in the middle or toward the medial side innervate proximal part of the arm. And alpha motor neurons that are located in the most medial side innervate axial musculature. So, if instead of a cervical segment, we consider a thoracic segment, then thoracic segment only innervates trunk, not limbs. So, all of the alpha motor neurons in the ventral horn are related to axial musculature. There is no lateral medial organization, right? So, alpha motor neurons that innervate flexor muscles are located backward in the ventral horn, right? Alpha motor neurons that innervate extensors are located
anterior.
So, alpha motor neurons that So for this movement are located anteriorly, alpha motor neurons that support this movement are located posteriorly. Right? So based on this, we will see that there are different type of descending pathways. But before that, let's see propriospinal neurons. Propriospinal neurons are neurons that have their somas in the spinal cord. So the soma of these neurons is in the spinal cord. The axons are also in the spinal cord. So the whole neuron is located in the spinal cord. They don't go out of the spinal cord. Right? So here you can see one of them. Soma is here. It has some axons that go upward and other axons that go downward. So they provide a connection between this segment and some segments above, some segments below. So it provides vertical connections. Right? Some of these propriospinal neurons are located laterally, like this. So they are involved in distal movements. Right? Some others are located medially, like this. So they are involved in axial muscle movements. Right? So this one, you can see, it sends the axons several segments upward, several segments downward. So it again provides vertical connection between the segments, but more segments than the lateral one. Right? And you can see that the connections are bilateral, because axial muscles should be contracted bilaterally. Because, for example, we want to do this movement, we want to move like this. So muscles on both thighs should contract. So the connection should be bilateral. So collaterals on this neuron go to the other side. And also we have other neurons on the opposite side that send the collateral this way. Right? So propriospinal neurons provide vertical connections. Then the third one, the third structure is descending motor pathway. So based on the arrangement that I mentioned here, lateral, medial, some of the descending pathways are called lateral descending pathways, others are medial, right? We mentioned this yesterday. So in the lateral system, we have lateral corticospinal and rubrospinal. So they start from cortex or from red nucleus, they come down, and they end on alpha motor neurons that are located laterally in the ventricle. And they are involved in contraction of distal part of the limb, arm or limb, right? So we call them lateral systems. But medial systems are descending pathways that originate from the brainstem or from the cortex and end on alpha motor neurons that are located most medially. So they are involved in contraction of proximal part of the limbs or axons. So ventral corticospinal tract, reticulospinal tract, vestibulospinal tract, sacrospinal tract are part of medial system. And another point here is that all of these pathways come down to the spinal cord and they make connections first with interneurons. Then interneurons make connections with alpha. So we have convergence of signals onto alpha motor. So alpha motor neuron is the final neuron in the motor system. It passes the signal to skeletal muscles, right? It receives information from upper centers. So all of other neurons are called upper motor neurons. So we have several upper motor neurons and only one lower motor neuron. So there is only one exception here. So most of the fibers here terminate on interneurons, and then interneuron pass the signals to alpha motor neuron, right? But there is one exception here. In the lateral corticospinal tract, some of neurons go directly to the alpha motor neuron without termination on interneurons. These fibers are mainly involved in the control of fingers. Okay? We call them corticomotor neurons. They come from cortex and they end directly onto alpha motor neurons. So we can say that more than 90% of fibers, these ending fibers, terminate first on interneurons and then on motor neurons, but a few of them, less than 10%, come directly from the cortex to alpha motor neurons. These neurons are mainly involved in control of fingers, right? Because movement of fingers is very essential for humans. So we need a very direct pathway from the cortex to the alpha motor neurons, right? So now let's talk about reflexes. So stretch reflex or myotonic reflex is the contraction of a muscle in response to stretch. So whenever you stretch a muscle, you increase the length, the muscle contracts. So the muscle opposes its stretch. Right? So the muscle doesn't like to be stretched. So it contracts, it opposes its stretch. So whenever the muscle is stretched, suddenly the large muscle fibers of the stretched muscle and also the synergistic muscles are contracted. So this is a reflex, so we need a receptor for it because it should answer to a sensory stimulation. The receptor here is muscle stimulation. Right? So we have a second type of receptor in the muscle, and it's Golgi tendon. So remember, muscle spindles are located in the belly of the muscle, in the high muscle. But Golgi tendon organs, or GTOs, are located in a muscle tendon. Muscle spindle is a receptor of length, but GTO is a receptor of tension or force. So this one is activated when you stretch a muscle, but this one is activated when a muscle contracts. Right? So they are different. The signals generated from these two receptors may have two different goals. The first one is to make the brain aware of the signals. The brain can be informed about the state of the body, the state of the muscle. Right? So they provide continuous feedback of sensory information from each muscle. So signals from here go to the brain, go to the cerebellum. Remember from yesterday's session? Spinal cerebellar tract. Right? I told you that dorsal spinal cerebellar tract originates from muscle spindles, Golgi tendon organs, joint receptors, right? Proprioceptive signals. But they also provide signals for reflexes. So now let's see the muscle spindle. Just like this. First, we have muscle fibers, right? Principal muscle fibers, or we call them extrafusal fibers. They are the main fibers in a muscle. They contract, they provide a force of contraction. They are innervated by alpha motor neurons. But we have muscle spindle here, which is covered here, right? And inside this capsule, we have some small muscle fibers. We call them intrafusal muscle fibers. So we have extrafusal, intrafusal muscle fibers. Extrafusal is innervated by alpha motor neurons. Intrafusal fibers are innervated by gamma. So these are not involved in contraction of the muscle. They don't provide at the force of muscle contraction, right? So, intrafusal muscle fibers don't have actin and myosin in the middle part. So the middle part doesn't have any actin or myosin, so it's not contractile. It cannot contract. But the two sides do have actin and myosin, so they can contract. So, innervation of the sides is by way of motor fibers, But innervation of the central part is by way of sensory. 1A and 2. All of them are myelinated. Right? 1A and 2. So, a muscle spindle, which is a receptor of LAN, can be activated when you stretch a muscle or when you activate gamma motor neurons. Let's see. Okay? So, consider this thing. Extrafusal fibers, intrafusal fiber. Right? So intrafusal fiber is innervated by 1A and 2 fibers. So if we measure action potential in 1A fiber, we can see that when the muscle is at rest, when there is no contraction, or when there is no stretch of the muscle, we have some action potentials. Why this happens? Because the muscle is at rest, but gamma motor neurons are active. Gamma motor neurons cause interaction of the two sides. Contraction of sides causes a stretch of the middle part. Right? What do we call this play, this game? So, tug of war? Yeah. When you play tug of war, you stretch the rope from sides. What happens to the middle? Right? The same happens here. We contract these two parts. The middle part is stretch. So stretch activates muscle spindle. Action potential increases in 1A and 2. So this happens when there is no contraction in the muscle. The muscle itself is relaxed. But gamma motor neurons are active. Muscle spindle is under the stretch. So it generates action potential. So in the resting state, it keeps generating action potential at a lower rate. But when we stretch the same muscle, we put more stretch, right, on the muscle spindle. So firing rate increases. When muscle contracts, it becomes shorter, right? Muscle spindle is released. So the number of action potential, so muscle spindle can send a positive signal to the brain or a negative signal to the brain. Positive signal means increase of the length, negative signal means decrease of the length. Right? So now let's see the stretch effects again. So this one is rectus femoris muscle. Muscle spindle is here. You stretch the muscle, length increases, muscle spindle is activated. Signals go through 1A fibers to the spinal cord. What happens in the spinal cord? It has two branches. One branch goes directly to the anterior horn. So it passes the dorsal horn, passes the intermediate zone, enters the ventral. It makes direct synapses of the alpha motor neuron. Alpha motor neuron goes to the same muscle. So we have a monosynaptic pathway. There is only one synapse here. Stretch of the muscle, activate the spindle. 1A fiber action potential increases. It activates alpha motor neuron. Alpha motor neuron causes contraction of the same muscle. Alright? So what happens next? Second branch. Activate an interneuron, which is inhibitory. It inhibits alpha motor neuron that innervates antagonistic muscle. So the antagonist muscle is relaxed. So we have contraction of the agonist, relaxation of the antagonist. What is the antagonist here? Semi-endinosis. Right? There is also a third branch, not shown here. So, you know that for every movement, you may have more than one muscle. Right? So the muscle, the principal muscle here is rectus femoris. But vastus intermedius is also a muscle that does the same function. Extension of the knee. Right? So, a third branch activates alpha motor neuron that goes to the vastus intermedius. So, let's refine our definition. Whenever a muscle is stretched, the same muscle is contracted, the synergistic muscle is contracted, the antagonist is relaxed. Right? But I told you that there is another fiber from the muscle skin, type 2 fiber. It's not here actually, but it should be there, right? So type 2 fiber brings the information to the spinal cord, but instead of synapsing directly onto alpha motor neuron, it first activates interneurons. And interneurons activate alpha motor neurons. So we have disynaptic pathway or multisynaptic pathway because we have at least 2 synapses, right? So type 2 fibers activate interneurons. Interneurons carry a direct signals to alpha neurons, right?
My question: why they didn't send the signal to gamma fiber?
So gamma fibers are not activated by muscle skin. I'll tell you.
So, Dr. A1 fibers are the 5% that you were talking about that go directly to alpha motor.
Yeah, when 1A fibers go directly to alpha motor. So, so do you want to stay or you want to go? Because you are in for the bus.
Yeah.
Can we continue?
I can continue. Okay? So feel free to go out if you want. Okay? Okay, so intrafusal muscle fibers are of 2 types. Some of them are called nuclear back fibers. Others are called nuclear chain fibers. So we are talking about intrafusal fibers.
Muscle spindle.
Not all of them are of the same type. Some of them are nuclear back fibers, others are nuclear chain fibers. So here you can see that the fiber has several nuclei, right? Nuclei are collected in the middle here, so they generate a protrusion like a bag here, so we call them back fiber.
Okay.
In other types, we have nuclei in a row. We call them nuclear chain fibers. So, nuclear back fiber generates dynamic response. Nuclear chain fiber generates
Static.
static response. Static and dynamic. I say. Okay? I'll give you the definition of dynamic.
What
and
is that?
static. But before that, so please memorize this. Nuclear back fiber generates dynamic, and nuclear chain fiber generates static response. So now, let's focus on the innervation again with more details. I told you that 1A fibers and 2 fibers innervate muscle spindle, right? You can see that 1A fiber actually innervates nuclear back fiber and nuclear chain fiber. But type 2 fiber mainly innervate nuclear chain fiber. So back fiber for dynamic, chain fiber for static response, right? So dynamic response is transmitted only through 1A. Static response can be transmitted through 1A and
One is
Group two.
Secondary.
Yes.
right? So dynamic response only transmitted by 1A, but static response can be transmitted through 1A and 2. So now, what is the dynamic response? Okay, we want to stretch a muscle and hold it. Okay? Stretch a muscle and hold it. Before the stretch, it has a length. After the stretch, the length is larger. increase. During the stretch, the length is changed. Right? So this is the length before the stretch, during the stretch, after the stretch. So, muscle spindle responds to the stretch. How? It generates action potential. Right? Action potentials that are made during the stretch are called dynamic response. Action potentials that are generated after the stretch are called static response. So 1A fiber carries both dynamic response and static response. Type 2 fiber only carries static response. So imagine that before the stretch we had 3 action potential per second. It's only an example, right? 3 action potential per second at rest. During the stretch, it goes up to about 10 action potential per second. After the stretch, it's about, let's say, 6 action potential per second. So it goes from 3 to 10, from 10 to 6. 10 is dynamic response, 6 is static. Right? Group 2 fiber only sends static. So, this was the response of the muscle spindle to stretch and hold stimulation. Stretch and hold. But we may have another type of stimulation, tap, like using the hammer. Right? So you have a very transient and a small stretch. So it's very fast and it's very short. So it's a dynamic response, right? Because the length is changing. It is not fixed. Right? So during the tap, during this transient stretch, 1A fibers send several action potentials, dynamic response. There is no static response because we don't have a new length, right? Because it goes back to the resting state. So there is nothing here in group 2 fibers. Got it? So when you use a hammer, a tap, you only activate 1A fibers. Right? Type 2 fiber is not activated. Why? Because for activation of type 2, you need a continuous stimulation. Continuous stimulation. But tap is only a transient stimulation. Right?
Yeah. So when we active the first fiber, they will active the first and second nucleus, the back and chain nucleus.
So tap, you mean?
Yeah.
Only activate nuclear back fiber. It doesn't activate nuclear chain.
Why?
I told you because chain fibers are only activated when you have a static response.
Okay.
Static response are actually made when you have continuous stretch or constant stretch.
So when we'll get this one? This is stretch.
Yeah, when you stretch the muscle and keep it. You stretch the muscle and keep it. You increase the length and hold it. Right? So when you slowly increase the length, then type 2 fibers are activated. When you increase the length suddenly, for a short time, only type 1 fiber is activated. Nuclear back fiber. Right?
Yeah.
So you can read other parts on your own. Let's see here. So stretch reflex has 2 parts, dynamic and static. For dynamic stretch reflex, we need rapid stretch, which activates 1A fibers. We can see an instantaneous and a strong reflex in 391. But when you stretch the muscle slowly, then you can activate both 1A and 2 fibers, and it causes constant muscle contraction. So you have this in our questions, right? I asked you, which one is not involved in patellar tendon reflex?
Muscle spindle.
Patellar tendon reflex, right? So 1A fiber is activated, nuclear back fiber is activated, right? Alpha motor neuron is activated, because alpha motor neuron is activated both when you both activate 1A fibers or 2 fibers, right? And type 2 fiber is not activated, right? In the patellar tendon. Gamma neurons are also of 2 types, dynamic and static. If gamma D, gamma dynamic, is activated, the dynamic response increases. What do I mean? So you stretch the muscle and keep it, right? I told you that before the stretch you have 3 action potentials. During the stretch you have 10 action potentials. After that you have 6 action potentials. So 3, 10, 6, right? If gamma D is active, then dynamic response increases. Instead of having 10, you may have 2 action potentials. So sensitivity increases. Sensitivity of muscle spindle to the stretch, right? If gamma static is active, then this part increases. Instead of having 6, you may have 8 action potentials. So the static response is exaggerated, right? So
what's the main function of the gamma?
So it can regulate the sensitivity of the muscle spindle. Sensitivity. Okay? If gamma activity is high,
Sensitivity for the length?
yeah. So I mean, when you stretch a muscle spindle, it may increase action potential from 3 to 10.
The muscle spindle?
Yeah, muscle spindle.
But we say we don't have action potential. No, we say we don't have a contraction.
Yeah. But if you have both gamma excitation and stretch, then firing rate is more.
Yes.
Instead of having 3, you may have 5,
Right.
and instead of having 10, you may have 15. So sensitization happens here, right?
Yeah.
It is sensitized to the stretch. Got it?
But
So now, gamma neurons are always active, right? Why? Why they are active? Because they are located in the anterior horn, right? They are located in the anterior horn. I mean, so there we have alpha motor neurons and gamma motor neurons. So there are some descending fibers from the brainstem that activate gamma motor neurons continuously. They originate from the pons, pontine reticulospinal tract. Pontine reticulospinal tract. I told you before, pontine reticulospinal tract is excitatory. Medullary reticulospinal tract is inhibitory. Remember yesterday? So the region in the pons is sometimes called bulboreticular facilitatory region. So from pons reticular formation, neurons come down through the spinal cord, they reach the spinal segment, right? They go on to gamma motor neurons. They activate gamma motor neurons. What happens next? Gamma is active, so the 2 sides of muscle spindles contract. Middle part is stretched. Action potential is made. It is sent by way of 1A fibers and 2 fibers to the spinal cord. It terminates on alpha motor neurons. Alpha motor neurons come back to the muscle, activate extrafusal fibers. What is the reaction? Contraction. Right? So, we have partial contraction even during the rest. right? Even when we don't have any contraction. So when we don't have any contraction, gamma is active, it causes a partial contraction. What do we call this? Partial contraction of the muscle. What do we call the partial contraction that happens even during the resting state? Tone. Tone of the muscle. So part of the tone is made by gamma tone. So it maintains muscle tone. Descending pathway, gamma motor neuron excitation, ongoing activity in 1A and 2 fibers, baseline rate of firing of alpha motor neurons, muscle tone. Right? So, okay, let's ignore this one. And
Not on the
also
exam?
this one.
Not in the exam?
Yeah, I want to ask you about this.
Oh, thank God. Thank God.
Okay. So, this is the clinical application of a stretch reflex. I talked about this. If you have a hyperactive reflex, I told you, it infers a problem in descending pathways. If you don't have the reflex, it means there is a problem with the reflex arc. Muscle spindle, 1A and 2 fibers, segment of the spinal cord, alpha motor neurons. There may be something wrong with these when reflex is absent. Right?
Yeah.
But when the reflex is hyperactive, it means the arc itself is intact, but probably there is a problem with the descending pathways. Right? So, large lesion in the motor areas of the cerebral cortex cause greatly exaggerated muscle jerks in the muscle on the opposite side. Right? So, clonus, you asked me, right? So, you are giving continuous stretch of the gastrocnemius muscle. What is the reaction? Repetitive contraction. So, in reflex, you have only one stimulation, one contraction in reflex. But in clonus, you keep the muscle stretched. The answer is repetitive contraction. This happens only when the descending pathways are hyperactive and the reflex pathway is sensitized. Right? So clonus, rhythmic contraction. It happens in visceral patients. Golgi tendon reflex. So I told you that if you stretch a muscle, it contracts. But Golgi tendon reflex is reversed. If there is strong contraction, the muscle is relaxed. Right? It's a protective mechanism. It protects the muscle from rupture, from actually breaking the bone, from dislocation of the joints, or rupture of the tendon. So when we have a strong contraction, the answer or the reaction is relaxation. So when tension on the muscle becomes extreme, there is an instantaneous relaxation of the entire muscle. The receptor here is GTO. You see the GTO, the muscle, tendon, at the junction of the tendon and muscle, we have muscle, and we have GTO. Inside the GTO, we have some collagen fibers. Right? Between the collagen fibers, we have the tip of the axon. So the fiber coming to the Golgi tendon organ, and it has several branches of between the collagen. So when muscle contracts, collagen fibers are tensed. Right? They keep pressure onto these nerves. It's activated. Right? Action potential goes to the fiber. Which fiber?
AB.
1B. 1A and 2 are involved in stretch reflex, 1B is involved in longitudinal. So they go to the spinal cord. In the spinal cord, they first activate an interneuron. So it's opposite to stretch reflex that directly activate alpha motor. Here, it directly activates interneuron. We call this interneuron 1B interneuron. 1B inhibitor. It inhibits alpha motor neuron. So alpha motor neuron is not activated, the muscle is relaxed. So in response to strong contraction of a muscle, the same muscle is relaxed. How? By way of 1B interneuron, alpha. That's it?
Yes. Doctor, for the fiber connection, the synaptic, you said in the spindle muscles, when the fiber come to the inside, like in the anterior, we have two branches, one directly synaptic and the other not direct. So, my question, this is in you mentioned to that directly, that one directly, and you said two we have two, directly and indirectly.
Yeah.
So if we bring it to you say right now, this
Here
is
we have only indirect.
okay.
Yes? So, indirect one is inhibitory.
Is it conscious or subconscious?
No, it's reflex. It happens subconsciously. It happens automatically. For example, you have seen weightlifting matches, right? So, maybe the person wants to lift the weight, but it's very, very actually heavy. So muscle is contracted very strongly, right? But it cannot lift the weight. So we have a strong contraction. After that, actually they bring the weights a little up, then they release it. This release is mainly reflexive because the muscle is under severe contraction, okay, but it cannot lift the load, so it is relaxed. Okay? So we have relaxation in response to strong contraction.
Does it also happen in people with epilepsy?
Epilepsy? No, it doesn't happen because in epilepsy, everything starts from the brain. So brain has a higher order place. Okay? So the muscle should react to the commands of the brain. So the last one, the last reflex is flexor reflex. So here, the receptor is not in the muscle. It's located in the skin. Right? It responds to pain, mainly. So if there is any pain, so when you touch something hot, you withdraw your hand, right? So how this happens? Pain receptors are activated. Signals go through pain neurons to the spinal cord. In the spinal cord, they activate several interneurons. Interneurons activate alpha motor neuron to the flexor, inhibit alpha motor neuron to the extensor. So flexor contracts, extensor is relaxed. What is the reaction? Flexor is contracted. So we call this flexor reflex. Flexion means going away from the object and going near the body. Right? So flexor is contracted, extensor is reduced. So we call this flexor reflex or withdrawal. So some of the interneurons go to the opposite side. In the opposite side, they activate other population of interneurons and they make a reverse pattern of activity in the opposite arm. So flexor is relaxed, extensor continues. So this hand touches the object which is painful. We have flexion here, extension in the other arm. So we call this flexor reflex cross extensor reflex. Okay? So maybe you hit your leg to something painful, you feel pain. The answer is flexion. The other leg should keep the weight. Right? So it needs extension. So flexion happens on the same leg, extension happens on the other. Right? So flexion and extensor. So which reflex is a spread, or which reflex spreads from the side of pain to the opposite side? Flexor reflex. Right? So maybe I give you answers like this, on the options like this. Stretch reflex, Golgi tendon reflex, flexor reflex, or maybe another one. Light reflex. I don't know. Okay? Which one goes to the opposite side?
Flexor reflex.
Sometimes the object is very painful, right? So you touch it, you show flexion in your arm, there is extension in the other arm, but you also contract your body and legs and you go away from the object. So the reflex spreads all over the spinal cord. So it spreads from the segment of interest to other segments. How this happens? By which structure? Which structure provides vertical connection between segments? We have three, right? Segmental, propriospinal, descending.
Descending?
Propriospinal structure, organization, provide vertical connections between the segments. So you touch the object, which segment is activated? Cervical. But you show contraction also in your legs. This means lumbar segments are also involved. How? The signal spreads from the cervical segments to lumbar one, propriospinal. Right? We have this in questions. Okay. So ignore this one. Ignore this?
Yes.
Very important, but let me talk about this one, the last one. So this is the last one, okay? For spinal cord. So, we have some descending pathways from the brainstem. Reticulospinal, the spinal, and from cortex we have corticospinal, we have rubrospinal. So they come down through the spinal cord. They make connections with alpha motor neurons, right? Some of them with gamma motor neurons. But these alpha and gamma motor neurons are the same alpha and gamma that are involved in reflexes. Okay? So because alpha motor neuron is activated by way of 1A fiber or 2 fiber, it is inhibited by 1B fiber. The same alpha motor neuron receives information from the corticospinal tract, reticulospinal tract, the scapulospinal tract. So all of these converge on alpha motor neuron. Right? So this descending pathways usually regulate the sensitivity of alpha motor neurons to incoming sensory fibers. So when there is a cut in the spinal cord, all of these pathways are cut. So they cannot regulate the sensitivity. Right? So the lower part of the spinal cord, I mean below the level of the cut, is intact, but it doesn't respond. You stretch the muscle, it doesn't respond. You give painful stimulation, it doesn't respond. Right? No reflex is functioning. So, why? Because descending pathway cannot regulate the activity. We call this spinal shock. So in the spinal shock, several things happen. One, arterial blood pressure falls down. Two, all the spinal reflexes are blocked below the level of the cut. Three, sacral reflexes for urination and for defecation are lost. So the patient cannot control urinary system, cannot control defecation, doesn't have any control on these, right? There is no reflex. Arterial blood pressure falls down. Why? Because sympathetic nervous system originates from the spinal cord. When the spinal cord has a clot, sympathetic nervous system is released from the control. It cannot be controlled. So activity in the sympathetic fibers declines, so it cannot constrict vessels. Blood pressure decreases. After a while, in humans usually after 2 or 3 months, reflexes come back. Why? Because we have a synapse, and synapse is something dynamic, it's not something fixed. So, 1A fiber, DRG, right? 1A fiber, make synapses with alpha motor neuron. Alpha motor neuron activates muscle, right? Descending pathways regulate the synapse. So from corticospinal tract, rubrospinal tract, vestibulospinal tract, tectospinal tract, and so on. They are lost now. This synapse is not activated by this descending pathway. So, you stretch the muscle. It is activated. It sends action potential through 1A fiber to the spinal cord. It reaches here. It releases neurotransmitter. But alpha motor neuron is not responsive to the neurotransmitter, so it cannot contract the muscle. So reflexes are lost. This happens during the spinal shock, right? After 3 months, it becomes responsive. How this may happen? So we are talking about the synapse. Let's see the synapse here. The synapse is something like this, right? 1A, alpha. So, neurotransmitter is released, it cannot activate alpha motor neuron. So the synapse sees that it's not responsive. So it takes some measures. What? It increases the receptors. What do we call this? Upregulation. What else? It releases more neurotransmitters. What else? It increases the number of synaptic terminals. What else? It increases the number of dendrites. So we have a sprouting of the axon terminal, sprouting and branching of the dendrites. Right? So one action potential comes here, it goes several ways, it releases more neurotransmitters, and neurotransmitters can bind to several receptors. So now this synapse is responsive. Right? After 3 months, usually. But when they come back, they are not regulated, right? So they are exaggerated. So if you hit the knee, instead of seeing something like this, you'll see this stronger answer. We call this hyperreflexia. So hyperreflexia happens after spinal shock. So spinal shock is ended, ends, and after that you have hyperreflex. Any question?
What about the slide before? It's skipped? Like we don't have it anymore?
This one?
Yes.
So these are some examples of autonomic reflexes.
This is
Sweating, local vasodilation. So intestinal reflexes. So let's talk about this. You have this in gastrointestinal system, right? So imagine that this is stomach. Okay, is it the stomach? And this is intestine. Right? Food is digested here, enters the intestine. When it enters the intestine, we have a stretch here. It activates some neurons. Neurons go to the spinal cord. Right? Then activate some other neurons that go to other areas of the intestine. So, stretch here, activate peristaltic movement here. What happens? When food enters the intestine, material inside the intestine is empty. They go forward. So we have more place for this food, which is common. We call this intestinal reflex. It starts from intestine, terminate on intestine. Okay, so this is another reflex. So we are talking about reflexes. We have seen some somatic reflexes, and there are also some autonomic reflexes. Baroreceptor reflex is another one. What else? No question? So, thank you so much for your attendance in classes.